Assalamu alaikum wa rahmatullah. Good evening, ladies and gentlemen. Thank you, Dr. Areem, for the kind introduction and for the organizing committee for a kind invitation. So, think of my talk as basically the news segment. I will just update you of what is going on with the molecular landscape. Definitely will not discuss anything basic. It's only FDA approved or something very close enough to the clinical use, especially in tertiary hospitals. And looking, so I'm not a hematopathologist, this is for the record, I'm a molecular and bioinformatician. So I come from that angle in the laboratory, and looking at the bone marrow initial workup, we need four specialty basically: the hematopathology, the flow cytometry, immunology, cytogenetic karyotyping, and the molecular studies. And in the last two groups, the cytogenetics and the molecular, we are really looking for different biomarkers, mainly the 5 groups: point mutations like the JAK2 that Dr. Conrad mentioned, insertion deletions, copy number variants, structure variation, and clonality testing. And we have this problem, the tunnel visioning, using one of the methods that we have. Each method will give us a very small window on a very large landscape of molecular abnormalities. And as also mentioned in the previous talk, it is going to be a molecular-based more and more, so choosing the right tool that is cost-effective, easy to use, is going to be of extreme importance if you want to keep up treating our patients in an up-to-date fashion. And why it is tunnel vision? If we just look at different methods that I selected that's commonly used and see they are good at different biomarker detection. This is the BCR, this is the FISH. It's both are targeted and not good for everything. Arrays is not targeted to whole genome, but it's very focused on copy number variants. NGS has the promise of detecting everything, but there is so many flavors, so many different types, difficulties and biases that comes with NGS as well. So in my talk, I will speak about 3 things. One is something called low-pass whole genome sequencing. It's NGS-based, but it's a different flavor, very cost-effective, and it's really close to the cytogenetics. So there will be a huge interaction between these two sections. The second is the clonoSEQ method for minimal residual disease testing. This is FDA approved recently, and it's very important and could work in concordance with the flow cytometry. And the last thing is the optical genomics. So this is relatively a new technology in the last 5-7 years, but it has a huge potential also in the cytogenetics. So cytogenetics will see a lot of new changes in the upcoming few years. And the idea here with this talk is to find out where to use these tools into actually moving from tunnel vision to a bigger landscape and seeing everything as much as we can in a cost-effective way. So let's start with the low-pass whole genome. What does low-pass? The key is low-pass. So the average of sequencing is usually in hereditary diseases is 100. 100 sequencing per target, enough to call a mutation in germline mutations. For somatic, usually you want 500 to 1,000, or even deeper if you want to go for MRD. Low-pass is 2 to 4 coverage. So you may wonder how good is 4 coverage to detect these alternatives. And you would be right. It's not good for point mutation. It's not good for insertion or deletion, the small ones. But it's proven to be fantastic for copy number variants, the large one, and structural variation. And this is a seminal paper published last year, and I had the pleasure to present it in one of the workshops to the Saudi Society. Published in New England Journal in March 2021. And basically, they use this method as an alternative to cytogenetic analysis in myeloid cancers. They have retrospective samples, prospective samples, combination of AML, MDS, and the retrospective, and 117 cases, also the same style. They compare it with FISH and karyotyping as well as targeted sequencing. And they use Illumina as their platform, which is, I will not go into technical details. It's a laser-based, image-based, and it is kind of the standard of sequencing in most of the clinical labs. So the first myth was NGS is complex, it's take a long time. This group in a tertiary hospital academic were able to produce the report within 5 days. So this is an amazing achievement and make it very close to the turnaround time for cytogenetics or FISH. It's still karyotyping is much faster on FISH, 1 or 2 days. But this is very impressive and shows what we are going to see in the next few years. This will be the reality. And during the study time, initially, they used to have need 2 to 3 weeks of turnaround time. As they moved forward and improved and optimized, they reached the 5 days from receiving sample to reporting the NGS report. And one of the most important findings is this. So all the 40 recurrent translocations and 91 copy number variants detected by karyotype of FISH were detected by this method, the low-pass whole genome sequencing. Not only that, they found new findings, completely new, in 17%. And actually, in the prospective cohort, they found in 19 patients, or 16%, they changed the risk category using something that's missed by karyotype or FISH. So this is a huge news, even in what we know today as biomarkers. And it was sensitive enough actually to detect as low as 13% of deletions. So that's fantastic. It's sensitive. It's not very sensitive for MRD, but it's amazing to reach 10%. But of course, on the published paper is not the reality. The reality, it is still big data, required specialized teams. It's costly, of course, and the logistic of this. However, I think these are changing so fast. In fact, yesterday, there was an announcement from the same company, Illumina, with their new and most updated machine. And this new machine is doubling or tripling to 260% the capacity of previous model, which means as cost goes, we would reach $200 per whole genome. So compared to this, to what's just mentioned in the, sorry?
Shocking.
Right. So the BCR-able testing, the averages was $260. This is $200 for the whole genome. And then I'm talking only about sequencing. Of course, the reality is this is double or triple if you have the overhead, the analysis, etc. But still, we are less than $1,000. So this is amazing news for everyone. Does that mean next week we can do it? No, of course it will take 1 or 2 years to reach this, but it is moving so fast, so cost will no longer be an issue in the next couple or 3 years. So I will move to the second development in the clonoSEQ MRD. This is basically where we are looking at 1 in 10, 1 in 1,000, up to 1 in million. And the deeper we go, it's very important for treatment decisions. And this graph represents the response and the minimal residual disease in the microscopic and the submicroscopic and the complete remission. And you will see different curves. Some of them are for FISH and cytogenetics working within up to 10 to the minus 2. But what we really want to go, the deeper we go, the more accurate the prognostic value of the method. And of course, flow cytometry is being used in this area a lot. But NGS is coming to this space big time. One of the companies is called Adaptive, I think, Biosciences, have this test, FDA approved, where basically they say at the initial time of diagnosis, we will sequence and detect a very specific DNA segment, and we will use it as to monitor the patient progress. And what they are using is the immunoglobulin GFD regions. And this combination in any given patient is 10 to the power of 11 zeros. So picking one of those clones could be used for the MRD monitoring in the patient. And it has been approved for multiple myeloma, for CLL and BALL at the initial diagnosis, induction therapy, stem cell transplant, consolidation, etc. So this is been used in many hospitals, especially in the US, I would say. If you would compare it with the flow cytometry, so the power of sensitivity is up to 10 to the minus 4 or 5, and I think the new generation of flow cytometry up to minus 6. It's extremely fast, the flow cytometry. It's very sensitive, relatively inexpensive. The issue here is usually it's required fresh cell required and significant technical expertise. Compared to the NGS approach, it's up to the -6. It's relatively rapid within 2 weeks, 7 days to 10 days. The problem is still it's expensive, but as I mentioned, this will change very soon. And the issue of lack of standardization. So this is still an issue, but it's going to change fast. So we may see NGS and flow cytometry will be used depending on the availability of it. Today, the clonoSEQ is a send out, and that's not good for remote areas or cities, or they're expensive. The good news is many companies are producing in-house solutions. So if you have NGS in-house, you could do the same thing in-house, but it will require some standardization. The last part is the optical genomics, which is really excited. It's been a while since we saw completely new technologies beside the NGS. And one of those solutions is called BioNano Sapphire. And basically, they have a microfluidic chip where they put the DNA at the beginning, and then they drag the DNA through a nanochannels. And the idea is the lumped DNA, as it passes through the nanochannels, it will be stretched. And once it's stretched, it will be imaged. So this is how the nanochannels looks like. The DNA segments will be passed through it. So there is no copying, no PCR, no enzymatic reaction, nothing. It's just a very simple method in principle. And they will start imaging those DNA segments as they pass through it. And the idea here, you will see the blue color is the DNA background, and the green colors is similar to what the cytogenetic bands look like. So it's a very specific region. The difference between it and cytogenetics is cytogenetics is a huge segment, while here the resolution is up to 500 base pairs, which is amazing resolution. And eventually, they take all these segments and map it to the genome, and then they can detect deletion or insertion, which is similar to the arrays. But what's different than the arrays, it actually can detect repeats, expansion, tandem duplication, balanced translocation, and inversion, which is usually something karyotyping only can do, beside the NGS. So almost all the variants of structure variants and copy number variants that we know can be detected by one method. And the initial studies show that it's extremely sensitive, up to 500 base pairs, for insertion and deletions, as well as for untranslated translocation up to 50 kb. So what is the promise? The promise of optical genomics is, they say, we could actually, at some point, not replace but complement what karyotyping, FISH, and arrays does for one patient in just one test. So this could be very cost effective and will bring a lot of answers for the patient in one report. And I will end with this study that was published last July, where they used this method in acute myeloid leukemia in 24 patients. So what they found is, in 6 patients, they were complete concordance. What karyotype FISH says, it's exactly what they saw. In 9 patients, understandably, it's not seen by karyotype, but seen by the new technology, which is also expected. In 6 cases in red, there was some discrepancy, but the overall result was similar. The cryptic regions in karyotyping was called something else in the optic genomics, but it's the end result the same. But what concerned me is those 3. Why karyotyping saw something that missed by the new technology? And it turned out, when I looked in the details, 2 of those cases were actually seen in only 3 cells out of 25, and did not convert by FISH or different methods. And only 1 case that did not have enough tissue to double check. So that was good news that the new technology is very concordance with the current practice. And this is the table that shows these 3 cases and the differences. So this is my last slide, where I highlighted in green the standard cytogenetics, FISH, and arrays. in red, the whole genome sequencing and targeted DNA and RNA. And finally, the genomic, the optical genomics. What I want to highlight is, think of whole, the mapping, the optical genomic as arrays on steroids. So it's not targeted. It's actually the whole genome. In terms of turnaround time, it's around 7 to 10 days. And in terms of the sensitivity, it's similar to the arrays, 5 to 20%. But it will only detect copy number variants, structure variants, not the point mutation, similar to the arrays. So this is where the NGS will play a major role. And in terms of costs, it's not that expensive, similar to array. Still expensive, but not crazy expensive. So with that, I hope that I managed to show flavors of new technologies that find its way to the clinics, especially the low-pass whole genome in cytogenetics. The summary here is the cost is amazingly dropped, and the turnaround time is reaching 5 days. clonoSEQ and similar methods could actually aid with the flow cytometry for MRD. And finally, if you are working cytogenetics, I urge you to consider optical genomics as one of the tools to be done in the lab to replace some of the tedious FISH and other tests. Thank you so much.